I think I've already said it before, but I started this channel because I often practice my talks, and I thought it'd be a good way to disseminate our work, to record those practices and put them up online. So this is a recording for a talk I'm supposed to give at McGill, focus on our work on technology to disseminate psychological interventions. I want to start off the talk by thanking my lab, really, because a lot of the work that I will be presenting is in collaboration with my lab. And for people that are not clinical psychologists, I think one helpful way of understanding the kind of work that we do is by situating it in the clinical translational spectrum of biomedical discovery. On this spectrum, at one end, you have research, usually on animal models, meant to uncover basic mechanisms of health and disease. At another end, you have work that is very translational, focused on practices out in the community and changing practice at a very large level. Squarely in the middle, the second stage of translational research is research that's done in clinical samples in humans. So they're real people, not animals, I guess. But you have a degree of experimental control over what the interventions are, who delivers the interventions, and to some extent who the patients are. But this is a spectrum. So sometimes it includes more preclinical research. So sometimes we do experimental work where we try to mimic a therapy process in a laboratory context. And increasingly, we are doing research on clinical practice and trials that emulate routine care, more in this third stage of translation. But you can see that on the human side of things, I have collaborators really across the spectrum. For today, very briefly, I will talk about the burden of depression and its definition. This is an area that I have contributed to, so I could say a lot more about this, but I'm going to give you a very brief overview of it. I'll also focus on issues and treatment research, of course, with a spotlight on issues that my work hopes to address, but I want to spend the bulk of the talk talking about our research on low-intensity treatments assisted by technology, including also what technology like social media can tell us about public attitudes about mental health interventions. Just to orient you a little bit to my slides, the references will be on the bottom right. When the reference is bolded, it's something by me or my team. When it's not, it's not. When I talk about depression, I'm referencing symptoms that are found in an official category in the Diagnostic and Statistical Manual of Mental Disorders put out by the APA, and specifically major depressive disorder refers to 9 symptoms. It's classified as a depressive disorder, so the person has to have mood symptoms, either the subjective feeling of depressed mood or loss of interest or pleasure in activities that they used to enjoy. That can't be the only symptom that a person has. They have to add up to 5 that include things like things in your body like oversleeping or undersleeping, either one would count, or cognitive symptoms like guilt or difficulty concentrating. In the United States, roughly 20% of adults remember a time of their life in which they met criteria for a major depressive episode, though you'd be better off conceptualizing it as a continuum that has this arbitrary cutoff. The depression then costs the US economy over $300 billion, primarily in the form of what it does to people's ability to work, right? Lost productivity, but to some extent direct medical costs. And across various indicators of disability that you could look at, mental disorders, but depression specifically are the leading contributors to disability in the US and worldwide. Luckily, we have effective psychological interventions. If you have a stereotype in your head of what psychological interventions are, like Freudian psychoanalysis, the kind of intervention that I research and have been trained to practice, cognitive behavioral therapy, is very different than that. So CBT, which was developed at the University of Pennsylvania, where I did my graduate training, is a therapy that is time limited, so it's usually months instead of years. It tends to be focused on the present instead of the past, and it tends to be focused on things that are easily observable, like problems in a person's life or symptoms that they are having. Unlike a lot of other psychological interventions, CBT is very well grounded in basic research. And so, for example, the behavioral parts of it are focused on decreasing avoidance and increasing the presence of rewarding stimuli in the environment. That has good backing in research, and the cognitive parts are focused on teaching people to look at situations from different perspectives and decrease their potential cognitive biases, and that is well supported by research on emotion regulation by cognitive reappraisal. So there's a lot of experimental research on this in humans. In the kind of T2 clinical research that I do, CBT is also well researched. It's in fact the most widely studied psychotherapy for depression. If a group of people undergo CBT, based on meta-analyses, you'd expect roughly 60% of them to have very large improvements, like a 50% drop in their symptoms. That compares favorably to various control conditions where 20 to 30% of people experience large improvements. You'll hear me use two control conditions throughout the talk. One of them is a waiting list control. The other one is treatment as usual. The names kind of give away what they are. In a waiting list control, you tell people not to seek treatment and to just wait until the end of the study, and then you treat them. In treatment as usual, and so that controls the passage of time, right? In treatment as usual, you don't prohibit people from getting treatment, and instead you allow them to get whatever treatment is available in the community. It usually won't be CBT. It'll typically be waiting or medications or psychotherapy that's non-manualized and typically not CBT. In clinical trials, CBT is better than both of these control conditions, although of course the effect sizes are weaker, are smaller when you look at the more strong, at the stronger but more heterogeneous condition, which is treatment as usual. It'd be a pretty boring talk if I just said there's a big problem, but luckily there's a treatment. There are problems in the evidence base of cognitive behavioral therapies. A big one is that CBT in randomized controlled trials tends to have small effects when compared to other psychological interventions, even those interventions that are not as well grounded in basic and translational research. So I'm showing you here the D-type effect size from the latest meta-analysis, comparing it to psychodynamic therapy, and the effect size is at 0.17. It's small, it's not significant, and people doubt its clinical significance. Not only does depression respond to a lot of different psychological interventions, it also gets better with the passage of time, minimal interventions like using apps for your mental health, but sometimes it also requires more complex work, right? Like pharmacotherapy, ketamine, electroconvulsive therapy. We don't really know, even though these interventions are all very different, we don't really know how to assign people to the type or level of intervention that is appropriate to them. And the way that we do this is usually trial and error, which is probably inefficient, and whether the treatment is available around you, which if you've ever tried seeking mental health care for yourself or a loved one, you know that it typically isn't. One issue in this country and elsewhere is that because there are not enough providers, when a person seeks psychological services, they usually have to wait a long time for the services. So a couple of years ago, we did a convenience study of therapists on social media where we asked them, suppose I were a patient interested in seeking treatment with you right now, how long would I have to wait for a treatment? And the average estimated time that these 140 therapists gave was like 3 to 4 months. If that doesn't sound like a lot, it's worth remembering when people seek psychological services, it's usually at a time when their symptoms are have exacerbated or have gotten intolerable, so they're seeking care. One issue with the fact that we make people wait is that it may cause them to disengage from the treatment process. So the data that I'm going to show you here are from our cognitive behavioral therapy research clinic. And when people call into the clinic, we do a very, very brief assessment to make sure they're appropriate. So, we would exclude people if they're suicidal, if they're very psychotic, if they're very suicidal, or if they're homicidal, right? Like if they're totally inappropriate. If they're found to be probably appropriate, they get put on this waiting list. And once a therapist is free to work with them, they start treatment. The waiting list at this time was roughly 3 to 4 months, close to what we found in the other study. And I'm showing you here what happens as people progress to the start of the treatment. You can see we lose 10% of the people because they were deemed inappropriate very quickly. But when people are made to wait, roughly 50% of them just drop out of the treatment process altogether. So this is treatment dropout. Before treatment has even started, we're losing people. We have data that are very similar from a clinical trial that I did in the first year of COVID. By the way, I would not recommend to do a clinical trial in a global pandemic. And this trial had a very similar setup. We screened 260 people over a 12-month period. We kicked people out if they were deemed not to be appropriate for the study. In this case, we kicked them out if their symptoms are too mild or if they're suicidal. That was basically the only criteria. And the people that were found appropriate had to wait for intervention The twist in this study is that the waiting time was only a week. So compared to 3 or 4 months, a week is not a really long time. You can see similarly here that across the 260 people, we lose some people, usually because their symptoms are too mild, so they kind of fail the screening. But still, during the short waiting period, we lose around 30% of people. That's before people even have had the chance to have intervention. Now, you could look at these data and say a couple of things. You could say, well, maybe you're just really bad at retaining people. That doesn't seem likely to me. Other people have reported similar findings. Or you could say, well, maybe people are doing this treatment shopping and they go to whoever will see them faster. And maybe, you know, if it'll take you 1 week to see them, they'll go somewhere else where they can be seen in 5 days. The data that I'm going to show you here, to me, argue a little bit against both of those possibilities. They're from the World Health Organization. And they're from the World Mental Health Surveys they did, where they asked people with depression if they sought treatment. And for the people that sought treatment, they asked them, was the treatment helpful enough that it took care of your symptoms? And if it wasn't, then did you keep going to seek more treatment? I'm going to show you here the number of people that found treatment helpful in the black and the percentage of people that persisted to that level of care. So if you can see already the first treatment. Of course, people are only being asked if they sought treatment, so the persistence rate is 100%, but only 40% of or so of people found treatment helpful. If you ask people that have sought 2 treatments, you can see in the gray only 80% or so of people make it to that level, but roughly 60% of everybody who does that finds treatment to be helpful. If you can follow it across the board, basically what you find is that if people persist throughout the treatment process, at some point they'll find something that's helpful to them. It's just that most people don't do that. And I'm showing you these data, even though they're from interview, because the data from randomized controlled trials say a similar thing. The more treatments you do, the more likely you are to get better, but the more people drop out. One way that I tackled this previously, this problem of how to assign people to the level of care that's appropriate to them in my lab, is by using machine learning methods to identify optimal responders to different psychological interventions. The context for using machine learning methods, so kind of like a data-driven exploration of what are the predictors of outcomes, should be a little obvious. Our work shows that depression is very heterogeneous in its symptoms, but also in the prognosis, kind of like how aggressive it is. Most predictors of treatment outcomes have been inconsistent and have small effects. And so we've used machine learning methods when there are a bunch of variables to try to identify a smaller subgroup that could predict outcomes, or adding up small effects of a bunch of different variables to predict who will best respond to treatment. I'm showing you here a couple of references for that kind of work. I'm not going to go into them. They all have one thing in common. The thing that they have in common is there was usually a randomized controlled trial comparing CBT to another intervention, where the average treatment effects were small or not significant. And when we use machine learning methods, we were able to identify people that differentially benefited from CBT versus the other intervention, and usually vice versa, right? So we were able to identify kind of like optimal responders. I'm being really vague about this for a reason that will become apparent in a second. This research is really cool. We continue it to some degree when we have the appropriate data sets for it. But one issue with this kind of work is that most studies have had very small samples. In these studies, the effect size for using machine learning algorithms is usually significant or greater than 0, but it's not always large. And when you put those two things together, it leads you to the conclusion that most of this work is probably underpowered for what it was trying to do, right? Because the effect sizes are small, but the sample sizes are also small. And most of these studies suffer from the lack of an external validation sample, right? So we're able to do a little bit of internal cross-validation, but there usually isn't a trial that's so similar and has the same variables that we can validate the model. Benchmarking studies in pharmacotherapy suggest that you need sample sizes closer to 600 to 1,000 to have adequate power to detect the effect of using these machine learning methods. So this is work that continues to some extent in my lab when we have the right samples for it, but I've grown increasingly skeptical of that. So over the past, maybe since 2017, 2018, a couple of years, my work has focused, instead of trying to identify the optimal treatment for people, trying to increase the availability of treatment in the first place. The context for this is that roughly 40 to 50% of people don't receive any treatment for their depression. The rate of people that get treatment that's adequate with consistent with clinical guidelines is even lower. So obviously the rate of people that get the machine learning recommended treatment is going to be even way lower than that. I already told you there weren't enough CBT providers for everybody who will become depressed. It's worth noting that there are health disparities in access to specialist services. And in addition to all those structural barriers, there are also attitudinal barriers. So a big reason why people don't seek treatment is that they want to handle problems on their own. And this fancy machine learning work doesn't really do anything about that. So what we've done over the past 5 or so years is really focus on the potential of technology and technology-based solutions to increase the reach of mental health services. Most of us have an idea of how technology has increased the availability of services, in the sense that during the pandemic, telehealth became really common because it's equally effective to face-to-face CBT, and it may reduce geographical barriers. One issue with telehealth psychotherapy is that it still requires a trained professional. So one of the ways that we study the integration of technology is by the provision of self-help. By self-help, I don't mean like, random books that you could find on like a bookstore, if bookstores were still a thing, but I mean evidence-based materials that teach you the kind of education and coping skills that you would learn in therapy, but they're giving it to you via an app, a web page, or a book. Randomized controlled trials suggest that giving people access to self-help is better than making them wait, right? It's better than just a passage of time. So it may address some barriers like cost, transportation, and provider availability. When you provide self-help and you also give a little bit of paraprofessional guidance, you tend to get better outcomes. By paraprofessional guidance, I mean training a coach, not a psychologist. In my lab, I train undergraduate students to do this. To give people a little bit of emotional support and to remind them to use the self-help material. When you give self-help like that, it typically tends to be better than putting people on waiting lists. And the difference between face-to-face therapy and guided self-help is very small, like a D-type effect size of 0.1. And so it's more effective than guided self-help, but it does require the presence of a coach that's been trained. Work by us and by others also suggests that sometimes these technology-based solutions, they can be very, very brief. They don't even need to be in the form of self-help material that you do weekly. So arguably the person that has popularized this research the most is Jessica Schleider, across several trials, including a recent one that had 2,500 adolescents. As she finds small effects of single session interventions, which, like the name implies, it's just like you sit down one sitting and you do this 20 to 30 minute intervention that teaches you education and coping skills. She finds that that's better than control conditions. The D-type effect size is 0.2, but it's very, very scalable, right? Most people are willing to do it. We recently completed a multi-site randomized control trial with, of course, Indiana University, but also including Ohio State, University of Missouri at St. Louis, and the University of Pennsylvania. In college students, where we similarly found a D-type effect size of 0.25 when comparing this brief CBT-based one-shot intervention with a waiting list control. So this may address, these very brief interventions may address this issue of dropping out while people are waiting for care because they're fully automated, right? Like you can do them without having to have somebody next to you. We're currently planning a mega study of 2,000 to 3,000 youth with partners at Northwestern and University of California at Irvine to test what the best brief single session intervention is for youth. I do want to come back to this idea that people probably need multiple interventions. So the aim of my work at least, is not to replace face-to-face therapy, but to figure out how to best combine low-intensity treatments with more traditional therapy. So I'll give you an example of a study that we recently did where we combined psychological interventions like this. So for this study, we partnered with the Indiana Center for Rural Engagement, which is of course very concerned about the mental health needs of Indiana, which ranks 42nd in terms of unmet mental health needs across the 50 states. And we did the study where we found people with depression or anxiety, and we gave them the option to do a single session intervention that is very brief. It's 20, 30 minutes. And then after a week after that, we randomized them so that everybody would get access to CBT-based self-help material, but roughly half of the people got guided self-help. So they got the self-help plus a coach, and the other half did the self-help, the low-intensity treatment on their own. The one thing that's notable to me about this study is that to compare guided versus unguided self-help, the power analysis suggested we needed, the sample size planning suggested we needed 260 participants. We only had 12 months to recruit people for the 6-week study, and the budget was around $20,000. We were able to meet this recruitment deadline and actually exceed it slightly with ease, right? And so that's kind of the potential of these interventions, is that they're a little bit easier to scale up. My philosophy in the lab is that I really like to go where people are at. In the United States, roughly 75% of people have access to a social media platform. So a lot of our recruitment happens via social media, and we've developed kind of sophisticated procedures to identify bots. I'm happy to talk about that. In the study, we screened through 350 people over the 1-year period. As in the study that I showed you before, that was the one I said not to do during the global pandemic, we only have 2 requirements for people. The one requirement is that their depression or anxiety has to be at least mild, and we treat depression and anxiety jointly because they're very frequently comorbid. And they can't be suicidal more often than not. So if you're suicidal more days than not, unfortunately, you get kicked out of the study. Although if you're suicidal only, sometimes you're eligible. So we had 275 people, and then we give them the option to do this very brief single session intervention during the waiting period. Everybody gets access to a CBT-based self-help material that's written at a 6th grade reading level, so it's very accessible. And half of the people do it on their own or unguided. The other half do it with the guidance by an undergrad. And the guidance in this study was just 3 to 6 weekly calls during a 6-week period. They could be kind of telehealth, or they could be done by phone if people are old school. It's really 15 to 20 minutes, very, very brief interaction. I'm going to show you the demographics. I'm kind of a little behind on time, so I'll just do the highlights. The gender composition is what we would expect for a sample of depressed individuals, roughly 75% women, people in their mid-30s, consistent with the demographics of the state. 80% of the people were white. In terms of SES, it's an interesting sample because there's a high degree of educational attainment. Roughly 50% of people have a bachelor's degree or more, but the yearly household incomes that people are reporting are below the state statistics. So the median was 35 to 49%. And there's a very high rate of both unemployment and people outside of the workforce. You can see here a couple of indicators of clinical need. Roughly half of the sample reported 4 or more adverse childhood experiences. About a third were currently thinking about death or suicide at least sometimes. Roughly 50% have very severe alcohol use. I'm going to show you what happens in the first part of the study, where we offer people the chance to do this single session intervention. By the way, I should say this is a non-randomized part of the study, which of course becomes very relevant. The reason we did this as non-randomized is because the community partners really wanted to make sure that there wasn't a subgroup of people in the study that always got the worst intervention, right? So if you had been randomized to not getting the single session intervention and not getting the coach, that would be a group of people that would get kind of like the worst, right? And so we went back and forth, and I decided I kind of like the idea of saying, when you participate in a study by this lab, you always have access to immediate help. So even though I had this like really nice rationale that we want to give treatment to everyone, only 40% or so of the people completed the single session intervention. There was, however, evidence that completing the single session intervention was associated with a lower likelihood of dropout. So the dropout rate for people who completed the SSI, the single session intervention, that again is very brief, is 14% relative to the people who didn't complete it, which is 32%, and relative to the pilot study we'd done before, which was almost identical, except that it was done across the US instead of just in Indiana. Now I know that this is, you're a smart crowd, so the fact that it's not randomized kind of makes the causal inference here very weak. I used propensity score weights with all the demographics that I showed you to try to match the sample of people who had completed the SSI with the people who didn't, and in another analysis, the people who completed the SSI in this study to the people in our pilot trial. In both of those analyses, it still seemed like completing the SSI was associated with a much lower likelihood of dropping out. But of course, we can't claim that it causes people to be less likely to drop out. It didn't, however, appear to reduce your depression or anxiety. So the effect size was in the right direction so that you were less depressed or anxious a week after if you did the single session intervention, but it was not a statistically significant change. So, for that first part of the study, kind of mixed findings, right? Like engagement increases, outcomes not so much. And now I want to talk about the more interesting piece, which is what happens when we randomize people to guided versus unguided self-help. And I'm going to show you here the first outcome is the trial entry criteria, the K6. It's this depression or anxiety scale. It goes from 0 to 24. More is more depressed or anxious. I'm only showing you here the ranges from 0 to 15 because most of the predicted data are within that range. In the K6, a 13 is considered severe and a 6 is considered mild and was our entry criteria. You can see here that people are starting off in this kind of moderate to severe range. Here are the predicted scores from an HLM predicting the K6 at each of the 6 weeks from the interaction of treatment and time, controlling also for whether people finish the single session intervention and what that does to change over time. You can see the guided self-help in the blue and the unguided self-help in the orange. And you can see, there's a big drop off from baseline to week 1. So that can be like a little regression to the mean. But after that, people in the guided self-help condition experience steeper drops in their depression or anxiety, which translates to a D-type effect size of 0.44. This is kind of close to what others have reported. It's really a small manipulation, right? Like the coaches don't require that much time and training, but it seems like it really helps the efficacy of the intervention. We don't just measure outcomes, we also care about potential mechanisms. So I told you one potential mechanism of CBT is that it helps people to increase the use of reappraisal, right? It increases the likelihood that you look at things from a different perspective when you're upset. I'm showing you here the results of the ERC, the emotion regulation questionnaire, the cognitive reappraisal subscale. Throughout the 6 weeks in the study, we collect these measures weekly. Again, you'll see the guided self-help is in the blue, unguided in the orange. The dotted line indicates the mean for a nationally representative US sample. You can see that participants in our sample start off a little bit lower than the average, right? They're people that are depressed or anxious, but over time they experience increases, especially if they were in the guided self-help condition in the blue. And so it looks like it moves some CBT mechanisms. We don't just measure that, we measure a bunch of things. So we measure how usable people find the intervention, how they feel like they're doing in their day-to-day life, their depressive symptoms specifically. Across all of these metrics, guided self-help was better than unguided self-help. The only difference being we asked people about their well-being, so their ability to like enjoy life and feel positive emotions and feel active and kind of like they can contribute and be happy. That the differences between the two treatment conditions were not statistically significant. Otherwise, the differences between the conditions were statistically significant, and they're not all large, right? Some of these effect sizes contain small values in their confidence intervals, but in each case indicates the intervention is better, the guided self-help is better than unguided self-help. We do one thing in this study, which is, which I learned from a colleague at Columbia, which is like, at the end of the study 1, you ask people questions about the feasibility of what the study 2 that you want to do. And so here we ask people at the end, if we kept the study going for a couple more weeks and you have the chance to be randomized to getting more treatment via telehealth, doing psychotherapy sessions that are regular, that are longer, but doing them via telehealth, would you be willing to do it? This pie chart has the responses. I'm bringing pie charts back. I feel like they've, they kind of fell off the map. But you can see in this pie chart that roughly 75% of people say, yes, I'd be willing to keep going in the study if it meant I could get psychological intervention. About 20% of them said, well, maybe I need to hear a lot more. And only a very small fraction of people said, no, I'm not interested in more work with you guys. So that's currently what we're planning with community partners at Indiana University, is a second study that would have a couple of differences relative to this one. One big difference would be that we would randomize at week 1. So I really like this idea of saying, hey, when you do a study with our lab, you always have access to like immediate help. One issue is that when we do that, the causal inference about what the intervention does, is a little murky, no matter how much we want to go back and control or use propensity scores. The other more major change is that instead we'll have a step 3 where we randomize people to CBT delivered via telehealth or a control condition that the community partners are currently helping us to iron out. Another change in this is that we would collect more text data to measure potential mechanisms of the intervention. So I'm really excited about these technology-based solutions because they really allow you to do the kind of clinical work that is larger, has more heterogeneous samples, and it's not as expensive as traditional psychotherapy research. I will say, however, that this is a research line around which there have been many promises, a lot of them really which have gone unfulfilled. So I told you, like, well, one thing that's good about these technology-based solutions is that you could disseminate them widely, right? Because they overcome a lot of barriers like cost and the availability of providers. But that hasn't really been a major priority in the field. And so last year we published this paper, which did something that I thought was extremely simple. We did the systematic review of randomized controlled trials of low-intensity treatments based on CBT for depression. And then we asked a very simple question: how many of the technology-based solutions in these trials are actually available to the public? So we found roughly 80 randomized controlled trials. Some trials tested the same intervention multiple times, so it actually ended up being 80 trials, but only 40 technology-based interventions across those trials. Does anybody want to guess how many of those trials had interventions that were publicly available? If this were a talk, I get numbers like 0, 1, 2. And that's not far from what is actually true. So only 6 of the 41 apps or low intensity treatments were available. Most of the interventions were not available to the public, even though that's part of the rationale for studying these interventions. To get this through peer review, the editor said, well, okay, this is a really cool finding, but I really want you to contact the person that created these technology-based solutions to make sure that you're right, that they're not publicly available. We did that with all these authors, and it found no difference. Only 6 of the interventions were available. So this is a science to practice gap where we're finding these things that are effective, but the people can't access them. With Akash Wasil at UPenn, we also looked at the gap from another end, which is look at the things that are publicly available. How many of them have evidence-based content? And the answer is that most of the things that are available to people, for example, in the App Store or Google Play, don't actually have bona fide CBT content. So that's one lost opportunity here, that we're just not making the interventions available for people. Another opportunity is the idea of integrating these things into routine care settings. So I already told you that most clinical psychologists, or most psychotherapists, I should say, not clinical psychologists, their practices are usually full. Most people keep a waiting list so that they ask people to wait for them until they can be seen. And the waiting list is estimated to take up to 3 times. Now, this is not a waiting list like a waiting list control. This is just you wait for care from a psychologist, but you could go doctor shopping, right? So my student Alison Piper a couple of years ago did this study where she asked a very simple question. She took the sample of 141 psychologists and asked them, when you put people on waiting lists, do you do anything with them, including, for example, giving them access to technology? We also asked them about books, support groups, really anything that could be considered an intervention. Only 16% of the providers recommended a low-intensity treatment for patients waiting for treatment. And this is a self-report, right? So probably the actual percentage that does it is a lot lower than that. When we ask people their attitudes, their willingness to use LITs during the waiting period, most people said that they were willing to do it. In these studies, we also do something to get a little bit past self-report, which is we tell people, oh, the study's over, thank you so much, you'll get the gift card, whatever. But then we say, hey, by the way, if you want to learn more about the subject matter, just click here. And we leave it a little bit ambiguous to people, but we track who clicks the link. Over 60% of providers engage, participated in this information seeking where they sought more information about low intensity treatments. Ali, I should say, also studied qualitative data on what it would take for providers to recommend a low intensity treatment resource for people in their waiting list. And in this sample of 63 providers, she identified a couple of barriers that if you do research on dissemination and implementation, would be kind of obvious, right? Like knowledge was one of the main things that people didn't seem to think was a barrier, just not knowing what to recommend. But there's a couple of barriers that require us to think about, right? So one of them is people seem to have really myths or misleading or wrong ideas about who would be appropriate to get a low intensity treatment. And they also had some concerns that as a field, we just need to do a better job with addressing, like, for example, what the legal liability is of telling somebody, hey, you should do this intervention. She's also done a systematic review of qualitative research on barriers that similarly suggests that people have positive attitudes about low intensity treatments, especially after they've interacted with them. But there are a lot of concerns about the ability to implement these in routine care settings. Our work also suggests that these interventions, although they have a lot of potential, are far from living up to their promise. So one promise about these interventions has that they could reduce health disparities, for example, in the US, because most people can access the internet at least once a day. Some people may see this as less stigmatizing than traditional services, and we actually have some data that's going to be published soon in JAME Reformative that across a bunch of different self-report and behavioral metrics, racial and ethnic minorities are they're more willing to use low-intensity treatments than their non-Hispanic white counterparts. However, we also know that there are disparities in internet access related to geography, digital literacy, which has been related to race and ethnicity. And in a recent meta-analysis that we did, we actually documented that the reporting and the representation of sociodemographic features like race, SES, country of origin, immigrant status, language, are very poor in randomized controlled trials of these technology-based resources. So, I'm kind of a neurotic and disagreeable person, and so I really like taking a critical view of this research, that there are a lot of things there are a lot of ways in which it holds promise for our ability to intervene in mental health, but a lot of the future directions have to do with dissemination and implementation, and there is a big gap in what we know these technology-based resources can do in clinical trials versus what people are getting out there in the real world. That said, I really think it's very promising to study how to integrate low-intensity treatments with traditional psychotherapy research, because these low-intensity treatments allow you to overcome a lot of the limitations of traditional research, including that they're not as expensive. When we have used social media, we've been able to recruit large numbers of people very quickly. And so I think that, it's very easy to be negative about social media, but it really facilitates the kind of work that we do. Across this work, however, we have noticed a downside of social media as it comes to mental health is that there is a lot of misinformation about mental health. So people have documented that social media has a lot of misinformation about specific health topics like COVID or monkeypox, or societal topics like election integrity. We did a recent invited review for Current Opinions in Psychology, where we documented that there really hasn't been that much research on mental health. But when people have done research, they actually find that there's a lot of misinformation about mental health on social media, particularly around topics like trauma and neurodevelopmental disorders like autism or ADHD. And also on the topic of men's sexual health, there's a lot of anti-masturbation, I guess propaganda would be one way of framing it. So a couple of years ago, we asked ourselves, well, what are people saying about CBT, right? We're saying social media can be a force for good for getting CBT materials like low intensity treatments out to people, but is there a downside? Like, is there misinformation about mental health? So we did this little study using TikTok, which is a video blogging platform that predominantly caters to youth, where we looked up cognitive behavioral therapy and rated the top 200 videos after we'd done a little bit of formative pilot work on what people were talking about. And we looked at the valence of the videos, whether they were describing CBT positively or not, who posted the videos, and then measured various data and metadata. We found that by and large, shout out to pie charts again here, the people who post about CBT tend to be mental health professionals, either coaches or other mental health professionals like psychologists and psychiatrists, but their videos get a lot of views, right? But roughly 35–40% of the videos are by non-professionals. By and large, these videos tend to have a positive sentiment. So roughly 73% of the time, they are positive. 23% of the time they are negative, and when they are negative, they are extremely negative. Now that the rate of negativity doesn't differ between professionals versus non-professionals, but negative videos get a lot more engagement than positive videos. So we then did a deep dive into what are the negative videos saying. And I'm showing you here the percentage of themes that are represented across the negative videos. The top two critiques were that the cognitive techniques in CBT were invalidating. They were a form of telling yourself that your problems are not as bad as you think they are. And really the top one was a claim that CBT was not effective. Now, I cast doubt on the efficacy of CBT when I said the effect sizes are small, sometimes they're limited to specific subgroups of people. These posts were saying, we know from studies that CBT is ineffective. They're always really funny because when people in the comments say which studies support that, the poster usually says, oh, you can just look them up on your own. There's a bunch of them. So these were the top two comments. The next set of comments were about neurodiversity and the appropriateness of CBT for people with neurodevelopmental disorders, as well as the efficacy of CBT for trauma. The neurodevelopmental disorder is kind of complicated, so I'm going to push that up to the end. The issue of trauma is really interesting because the most effective psychological interventions for trauma and stressor-related disorders are forms of cognitive behavioral therapy, like cognitive processing therapy, prolonged exposure, trauma-focused CBT. Even treatments like eye movement desensitization and reprocessing arguably have very, very strong CBT components like imaginal exposure and cognitive restructuring. For the sake of time, I'm not going to show you this video here, but in this video, the poster claims that the limbic system and the prefrontal cortex don't talk to each other at all, and CBT is trying to treat the prefrontal cortex, whereas your trauma happens in the limbic system, so it's actually harmful because these systems have kind of like a language barrier. They can't talk to each other. So that, is not great. And we've more recently tried to explore, like, is it done pilot work to understand, is it about CBT per se that people are spouting negative attitudes, or is it about therapy in general? Our pilot data suggests that really when people are logging online to talk about CBT, they usually have like a reason to do it, right? It's usually like they like it a lot or they don't, whereas the discourse around therapy tends to be a little bit more vague and it's usually less emotional, right? So it's sometimes about basic facts or misconceptions about therapy. So I'm very excited really about the potential of technology. I showed you one way in which technology can be good for us in that it really allows us to disseminate material that's relevant to treatment. I showed you some areas where there are where we can still make some progress into actually making sure that the technology-based material that we produce reaches the right people and the people that we are promising to help. And I also showed you an area in which maybe technology is not great in the sense that it facilitates misinformation. That said, I think this issue of misinformation is really, really complicated. One way to frame this issue of misinformation would be to focus on the misinformation as really addressing specific concerns that people have, including negative experiences they've had with psychological interventions. So I actually think of these videos give us a sense of how we can train providers to best deliver CBT. I won't get into it in all of it, but this cognitive piece of CBT, although it's hotly debated sometimes, actually seems to be an effective piece of CBT that links with research on emotion regulation. But it is also possible, or it seems to be the case, that people find that to be invalidating, right? So I think this gives us an opportunity to think how we train people, especially how we train people in the behavioral, in the cognitive piece, that it can be perceived as invalidating, even though it may be a core mechanism of CBT. For the sake of time, I'm gonna wrap it up here, but basically I've been alluding to some future directions in the use of technology, including combining low-intensity treatments with traditional care, integrating low-intensity treatments into routine care, and addressing misinformation on social media as sort of major directions in my lab. I want to acknowledge that this work had several funding agencies. I do have a conflict of interest in that I consult with digital health companies, but if you're walking out of it thinking that that I have this bias towards digital health companies, I'm happy to talk in more depth about the limitations of digital technologies if you feel like I haven't done so already. And I'm happy to take questions via YouTube in the comments.